Hi, this is Steve Treon. I've been tasked today to talk about Waldenstrom's macroglobulinemia, and I hope over the next few minutes I'll be able to give you a nice progress report on what's happening in this disease. Now, I think it is important when we talk about Waldenstrom's to talk about the many ways that this disease can present. For many patients, the disease is centered in the bone marrow and can cause anemia, as well as a reduction of other blood counts like the platelet count or the white blood count. But for other patients, the disease can manifest because of the IgM protein that's produced by the Waldenstrom cells. And if you make too much of it, this can lead to hyperviscosity syndrome, where the blood becomes quite thick and you start seeing nosebleeds, headaches, as well as impaired vision. Also, the IgM can attack various body structures and can lead to anemia. It can lead to neuropathy. In some patients under cold conditions, the IgM can precipitate and it can block blood flow. There's also a component of the IgM called the light chain that can also be a problem. It can cause amyloidosis, which is when the light chain protein infiltrates various organs. We also know that the tumor cells can produce hepcidin, and this can lead to iron deficiency anemia. And we often look for this as a cause of anemia in patients with Waldenstrom. But I think it is also important to mention that the disease, at least at time of diagnosis, but more so when patients relapse, can also be found in the lymph nodes and spleen. We call this extramedullary disease. And also can infiltrate the brain in some patients, causing Bing-Neal syndrome. So it is important to keep this in mind because the ways we treat patients can be impacted by the way the disease can present. Now, primarily we've used rituximab-based therapy to treat Waldenstrom's. With rituximab alone, which is a monoclonal antibody, you see responses in about 20 to 40% of patients. You almost never see complete responses, and the benefit lasts somewhere between a year and a year and a half time. But with combination therapies, particularly with proteasome inhibitors, such as bortezomib or Velcade, or bendamustine, you start seeing much higher overall responses, approaching 90%, but still complete responses are fairly lackluster, ranging between 5 and 15%. But the benefit, even so, can be very long, between 4 to 6 years time before a patient requires retreatment. And so it is important to keep in mind this type of therapy for Waldenstrom's, which we call chemoimmunotherapy, because we're relying on the immune system. Now, some of these drugs can have side effects, like rituximab can cause a flare in the IgM. The IgM can go up abruptly. If this happens, this can induce hyperviscosity crisis. We tend to avoid using rituximab when the IgM is above 4,000. Fludarabine used to be a drug we used to use in the past, but this was associated with transformation of the disease to a more aggressive lymphoma. Bendamustine is a great drug. We try to use 4 cycles instead of 6, which many in Europe do. And we are very cognizant of the fact that even in a small percentage of patients, you can see acute leukemia or myelodysplasia as a side effect. For this reason, we want to avoid over-treating patients with bendamustine. And bortezomib or Velcade is a proteasome inhibitor, but it's associated with a lot of neuropathy. We tend to use once a week dosing as opposed to twice a week, which is how the drug was developed in order to minimize neuropathy risk. Now, one big breakthrough in this disease was the discovery of the MYD88 mutation. This was discovered in my laboratory thanks to whole genome sequencing. This is a mutation that's found in 95 to 97% of patients. And this slide is really meant to depict over 10 years of work, largely done by the person shown in this slide, Guang Yang, which was meant to show how MYD88 works, how the mutation in MYD88 triggers a vast array of signaling that supports the growth and survival of the Waldenstrom cells. And I want to call your attention to one very key component of this signaling network, which is Bruton's tyrosine kinase, or BTK. And it's for this reason in this discovery that enabled BTK inhibitors shown here to be developed for Waldenstrom's that resulted also in the approval of two of these, ibrutinib as well as zanubrutinib, for the treatment of symptomatic Waldenstrom's macroglobulinemia. Now, what you'll see in this slide, it's a very complex slide, but it shows you what these kind of discoveries can do. They can trigger a lot of clinical trials. In this case, BTK inhibitors, ibrutinib, zanubrutinib, acalabrutinib, tirabrutinib, pirtobrutinib. All these were trials done in Waldenstrom patients. And what we learned from these trials is that BTK inhibitors are in fact quite active. You see on average about 90% of the patients get an overall response, and about 80% get a major response, which is a reduction by about 50% in the disease burden as measured by IgM. I'm going to come back to that point towards the end of my talk. VGPR means very good partial response, which means a 90% reduction in disease burden, again measured by IgM. And what I think is also very important and worth being excited about is progression-free survival, because this denotes the time that disease is kept in check. And on average, BTK inhibitors do result in long-term progression-free survival. Now, one of the important impactors of how BTK inhibitors work are CXCR4 mutations. These are the second most common mutations found in Waldenstrom. We see them in about 30 to 40% of Waldenstrom patients. This was discovered thanks to my colleague Zachary Hunter using our whole genome sequencing data. And when you see these CXCR4 mutations, you in fact, see that the time it takes to get a patient into a response lags. Let me take example here, our ibrutinib study. This was the study that led to the approval of ibrutinib. If you had the CXCR4 mutation, the time it took to get to a major response was 4.7 months. But if you didn't have the CXCR4 mutation and only had the MYD88 mutation, it was 1.8 months. So, and you can see this down, the line here with the other trials too. Also, the depth of response was much lower if you had a CXCR4 mutation. Let's take, for example, the major response rate in this pivotal trial, 68% if you had the CXCR4 mutation, 97% if you did not. Look at VGPR, the depth of response here, 9% if you had CXCR4 mutation, 47% if you didn't, if you had only the MYD88 mutation. And you can see also differences in how long the response lasts. If you're only MYD88 mutated, 70% of the patients at 5 years had no progression of their disease, 38% if they also carried the CXCR4 mutation. So for this reason, we've been looking for ways to improve on outcomes related to BTK inhibitors. I'm going to talk about this big trial called the ASPEN trial. This actually pitted zanubrutinib against ibrutinib. There were two cohorts here, one which was made up of those patients that had the MYD88 mutation, the other made up of patients who did not have the MYD88 mutation. This is about 5% of all patients. In this case, they only got zanubrutinib. So what did we learn? Well, we learned that both drugs are very, effective. In fact, the major response rate was identical. Numerically more deeper responses, the VGPRs, were seen among zanubrutinib patients. This was based on data with a follow-up of 44 months, so quite a long follow-up. Now, what about those patients that had no MYD88 mutation, the so-called wild type? Well, even here, zanubrutinib was active. 65% of the patients had a major response. And so these are very exciting data. It does show you, in fact, that we have drugs that are very active in Waldenstrom's. But what was different here was zanubrutinib actually produced deeper responses among people that had the CXCR4 mutation. Even here, looking at the progression-free survival with a estimation at 42 months of treatment, 73% of the patients on zanubrutinib remained free of progression, so their disease was still kept in check. versus 49% for those on ibrutinib. So it does show you an advantage for CXCR4 mutated patients, using zanubrutinib. Now, there was also another potential advantage, and that has to do with side effects. We do see atrial fibrillation, arrhythmia of the heart, which is associated with ibrutinib. In this trial, in fact, the atrial fibrillation rate was 23% compared to 8% for zanubrutinib. Conversely, for patients that had that were on zanubrutinib, there was more neutropenia, meaning the white blood count was decreased, particularly at a very high grade in comparison to ibrutinib. But there was no infection signal, interestingly, associated with this difference. Now, one big point these days that comes up all the time is, should we be giving BTK inhibitors in our patients who are seeing treatment for the first time, or should we be using chemoimmunotherapy? And I'm going to tell you, there was a very large multinational but retrospective study that examined this question. And the bottom line is both patient groups did well. In fact, there was no difference statistically in progression-free survival or overall survival. So you don't go wrong, using one over the other. But there may be other considerations, and this is where we're working on better understanding some genomic alterations, which might be important to consider. There is this other mutation called TP53. This is a very interesting gene. It's a gene that sort of surveys the entire genome for mutations. And mutations happen every single day to our genome. But you need something that comes along and acts as sort of the proofreader and stops the cells from growing when, in fact, there is a very important mutation that may have been generated. Now, as part of the ASPEN study, they did a biomarker analysis, and this was meant to look at the impact of the different mutations, which we already talked about, MYD88 and CXCR4, but they also looked at TP53. What did they find? Well, what they found was that when you looked at all the patients on the study, both the MYD88 mutated and the wild type, 25% of the patients had a TP53 mutation. It was more likely to be present if somebody had been treated previously as opposed to not being treated. And I think this is a very important distinction, because when you look at this trial, what you come away with is understanding that most of those patients that were treated received an alkylator drug like bendamustine or a nucleoside analog drug like fludarabine. So potentially these were the reasons why the TP53 rate was much higher in previously treated patients. Again, this needs to be shown, but it does. These studies do raise this concern. And you may say, well, what does this mean? Well, there have been studies that have looked at TP53 mutations in Waldenstrom. Some have suggested a reduction in survival. Some have suggested, as this one does here too, that even if you are on a BTK inhibitor, your response is not going to last as long. Now, what we also know from the ASPEN study is that if you do have a TP53 mutation, you're much better off using zanubrutinib, because you'll see a better response rate. In fact, you can look at the differences here. Major response rate 63% for ibrutinib with TP53 mutations versus 80%. And even those deeper VGPRs, 13% versus 35%. There was no real big difference in terms of progression-free survival. Slightly better in favor of zanubrutinib, but you can see the difference here, 58 months versus 62 months. So how do we optimize now that we have these exciting drugs, using BTK inhibitors? And whenever one thing happens in oncology all the time is that once we find a drug that's very active, we try to combine it to make it even more active, just like rituximab, as I showed you earlier. We've had an interest in using CXCR4 blockers for those patients that have the CXCR4 mutation. In fact, we had great results using an antibody called ulocuplumab that blocks CXCR4 along with ibrutinib. In fact, everyone was a major responder. A third of the patients were VGPR responders. Unfortunately, this drug was discontinued by the manufacturer because it was not economically sound. And developing it for a small disease like Waldenstrom's wasn't enough to motivate them. This is a study where ibrutinib was combined with venetoclax. I'll tell you a few words about venetoclax in a moment, but I want to show you here a study which was just published in the journal Blood. It was led by my colleague Jorge Castillo, which actually achieved great results. Combining these two drugs, in fact, resulted in a major response rate of 96%, and 42% had a VGPR. And in fact, if you look at the CXCR4 mutation status, it made no difference. In fact, both of these populations responded very similarly. Unfortunately, 9% of the patients on this trial had a ventricular arrhythmia. And there were also patients that died because of these ventricular arrhythmias. And for this reason, this is an example of why we need to do clinical trials to better investigate these combinations. In CLL, and in mantle cell lymphoma, the same study was done, same drug combination, same dosing schema, and yet this signal wasn't found, which is why, once again, trials that are dedicated to Waldenstrom are very important. But there may be a bright spot in terms of combining drugs. This is a study from Canada from my colleague Neil Berenstein, who combined acalabrutinib with bendamustine Rituxan. And in fact, he's seeing a VGPR rate that's almost 70% in the patients that were treated up to 7 cycles of therapy. There were side effects, including neutropenia, which is, again, the white blood count being decreased, in some cases associated with infection. And we're going to hear more about this trial, hopefully this year, at the 12th International Workshop on Waldenstrom's when it occurs in October in Prague. Now, how do we manage BTK inhibitor resistant disease? Now, I'm going to tell you there's a lot of excitement these days, particularly on the use of a new BTK inhibitor, one that's called non-covalent. This actually binds to a different part of BTK than ibrutinib or zanubrutinib or acalabrutinib, which are called covalent BTK inhibitors. And what my colleague here, Leah Palumba, as well as others who participated in the study, showed is that even among patients that saw prior covalent BTK inhibitor, the major response rate was 67%. Even 25% of the patients had a VGPR. So very active therapy. The median progression-free survival, which is the average time that the disease was kept on check, was 19 months for these people who had already seen a covalent BTK inhibitor. So very, very exciting data, giving us yet again another drug that we can use after somebody has been on a drug like ibrutinib or zanubrutinib or acalabrutinib. Now, venetoclax. Let's just talk about venetoclax. This actually blocks a molecule called BCL2. BCL2 actually is very important for the survival of Waldenstrom cells. And my colleague, Jorge Castillo, in this study showed that venetoclax was very active. It produced a major response rate of 81% in patients, including patients that had seen previously a BTK inhibitor, including patients that had CXCR4 mutations. In fact, very similar outcomes were reported in this trial. So what does the future hold for Waldenstrom therapy? So just a few keynotes. One is that other BTK inhibitors are being looked at in combination with bendamustine Rituxan. This is a trial being led by Andrew Brannigan at Mass General. It will also be open at our institution. It only involves 15 months of therapy. The Berenstein trial was only 12 months. So you can see that by combining these drugs, the hope is that you can not have to have patients on BTK inhibitors, without a limited duration. Now, BCL2 inhibition is also exciting, and I just want to actually skip to this slide where my colleague Jorge Castillo is combining venetoclax along with pirtobrutinib. This is, again, that non-covalent BTK inhibitor that Leah Palumba and colleagues have been working on. Pirtobrutinib seems to have very little arrhythmia potential, at least based on the data that's been generated so far. So we're excited about this trial. It's going to be happening in relapsed refractory patients, patients that have already seen therapy, but also Leah Palumba is also looking at this in patients that have not been previously treated. She's based at Memorial Sloan. We hope to have that trial also open at our institution. There's also a new BCL2 inhibitor, sonrotoclax. This is one to get excited about because some of the preliminary data in previously treated patients showed a major response rate of 86%. And in fact, many of these responses were even durable based on the short follow-up. So again, a new BCL2 inhibitor, sonrotoclax, that we're currently investigating. There's also another interesting drug, pacritinib. This is being looked at for a clinical trial. We reported data with this drug. This actually can affect many different signaling networks associated with MYD88. It can block, HCK, which is above BTK, and therefore shut down BTK. It can block the EROX. And for this reason, it may be a drug that can better control MYD88 signaling. And in fact, this abstract that was presented by my colleague Sharon Liu at the American Society of Hematology meeting showed, in fact, that pacritinib produced higher levels of tumor cell killing compared to zanubrutinib. And in fact, when it was combined with venetoclax, you can see it had really the most robust killing effect on MYD88 mutated tumor cells. There's also a lot of interest in developing bispecific antibodies. You may have heard about these. These are antibodies that can bind to the tumor cell, bind to immune cells, bring them together, as you see here in this slide. And this allows then the immune cell to kill the tumor cell. And so Gottfried von Kudel at the Beth Israel Deaconess Medical Center here in Boston will be championing this trial for the treatment of Waldenstrom's macroglobulinemia. Now, you probably have also heard about CAR T cell therapy. CAR Ts are actually T cells that have been engineered to look for targets on tumor cells, specifically in this case, CD20 that's present on Waldenstrom cells. My colleague and friend Mazar Shadman, who's based at the Fred Hutch Cancer Center in Seattle, has run this small pilot study, in fact, showing even in patients who have seen a lot of prior therapy, he showed activity for the drug. And let me just go over his data to show you that the prior lines of therapy, 7.5, meaning patients had seen on average over 7 therapies in this trial, and yet the major response rate was 67%. So this trial actually will be opening at our institution very, very shortly. This drug, which is produced by Mustang Biosciences, this has received actually a fast track approval or a breakthrough designation by the FDA. So we're very excited about being able to look at CAR T cell therapy in Waldenstrom's. And in finishing here, I just want to acknowledge all the members of the Bing Center for Waldenstrom's, both our basic science team, our translational team, our clinical research team, and our clinicians who help make all this progress possible. And we would be nowhere without our supporters and funding agencies who help make all this progress possible. And with that, I'd like to stop and thank you so much for your kind attention.